Welcome to this custom-tailored deep dive. So imagine you're sitting in a clinic, say, in Chicago, right? You hand your chest CT scan over to a world-class radiologist.
Right, a top-tier expert.
Exactly. They look at all the intricate patterns of your lung tissue and they hand you a diagnosis.
Mm.
But now, imagine taking that exact same scan, the exact same pixel-for-pixel image to an equally brilliant doctor in New Delhi.
And you get a fundamentally different diagnosis.
Yes. Not because someone made a mistake, but because the actual medical rule books they have to use, they literally change depending on your zip code.
It's why, I mean, it really shatters this illusion we have about medicine being this realm of, absolute binary certainty.
Right, like a broken bone is a broken bone.
Exactly. We want to believe a lung scar is a lung scar universally. But modern diagnostics, especially in these complex pulmonary diseases, they rely on algorithms that are deeply, deeply influenced by population statistics.
It's just mind-blowing. So today, you and I are jumping into this fascinating 2024 study. It was published in the journal Radiology, Cardiothoracic Imaging.
A really prestigious journal for this kind of work, yeah.
Yeah, and we're looking at a condition called Hypersensitivity Pneumonitis, or HP for short. The whole mission of this deep dive is to explore the biological mechanisms of this disease, understand how these experts actually decode thin-section chest CT scans, and uncover this surprising statistical paradox at the core of our medical guidelines.
That's a great roadmap.
Okay, let's unpack this. What is actually happening inside the lungs of someone who has HAP?
Well, hypersensitivity pneumonitis, it's a form of interstitial lung disease, or ILD.
Okay.
And these are conditions that affect the interstitium, which is basically the lace-like network of tissue that supports the air sacs in your lungs.
Got it. So what triggers it?
It's specifically triggered by recurrent exposure to inhaled airborne pathogens.
Mm-hmm.
But the critical biological mechanism here is that it's a non-IgE mediated immune response.
Wait, non-IG. So we aren't talking about a standard allergic reaction, right?
Yeah.
Like if I inhale pollen and my eyes water, that's an IgE-mediated response.
Right, exactly.
Histamines flood the system, you take an allergy pill, and it clears up.
Yeah, it's exactly the opposite of that swift reversible reaction. In a non-IgE response, like a type 3 or type 4 hypersensitivity, you are seeing a much more insidious delayed cellular reaction.
Insidious how?
Well, when a patient inhales the specific antigen, whether that's, agricultural dust, proteins from bird feathers, or even just mold from a humidifier.
A humidifier. Wow.
Yeah, it can be really common stuff. Their immune system sends T cells and macrophages flooding right into the lung tissue. And this creates chronic parenchymal inflammation.
Okay, so just constant inflammation.
Constant. And over time, that state of inflammatory warfare, it stimulates fibroblasts. Those are the cells that start aggressively laying down excess collagen.
Which is the mechanism for pulmonary fibrosis, right? Like scarring. I picture this like a home security system going completely haywire.
That's a good way to look at it.
Like, usually a pathogen enters, the body sounds an alarm, you get a fever, and then the intruder is gone and it passes. But with HP, the immune system detects the intruder and just panics.
Right, total overreaction.
Instead of just sounding the alarm, it starts boarding up the windows, ripping out the drywall, and literally pouring concrete right into the living room. It permanently alters the architecture of the lung.
That's exactly it. And that structural alteration, it's irreversible. The lung tissue goes from being this spongy, flexible organ designed for gas exchange to something rigid and stiff.
That sounds terrifying.
It is. And because of this, the medical community recently had a massive paradigm shift in how they view the disease. Historically, pulmonologists, they classified HP based on time.
Like how long you've had it.
Yeah, they'd ask, is the patient's condition acute, subacute, or chronic?
But they threw those categories out, right?
Entirely. Toss them out. The newest medical standards focus solely on the physical presence or absence of that concrete you mentioned.
The fibrosis.
Right. The classification is now purely based on whether there is fibrosis, which places an enormous burden on the radiologic and histologic assessments.
Because they have to see the concrete.
Exactly. The high-resolution CT scan has become the absolute arbiter of truth here, because identifying that scarring early is literally the only way to intervene.
And the treatment isn't just a pill, is it?
No, the primary treatment isn't necessarily a drug at all. It's identifying the environmental trigger and physically removing the patient from it before the damage spreads.
Which is incredibly difficult because of the sheer volume of potential triggers.
Yeah.
I mean, the source text highlights that there's an almost inexhaustible list of inciting exposures.
Oh, absolutely.
And it heavily depends on local environments, agricultural practices, climate, which creates this wildly uneven map of who actually gets the disease.
What's fascinating here is how the data captures that environmental geographic heterogeneity. Like the authors of the study, they practice at a specialized ILD center at the University of Chicago. And at their center, HP accounts for roughly 12% of their ILD cases.
Which is a significant portion, but, still a minority of the patients they see.
Right. And if you look at the nationwide registry data across the U.S., pulling from over 60 different centers, the purported prevalence actually drops to about 8%.
So it's relatively uncommon overall in the States.
It is. But shift the focus globally to India, and HP accounts for an astonishing 47% of all patients presenting with new-onset interstitial lung disease.
Wait, 47%, almost half.
Almost half the patient population in those specific clinics has this exact disease.
That is staggering. And that's driven entirely by the specific occupational and environmental pathogens floating in their local air.
Exactly.
So if the stakes of misdiagnosing this disease are permanent, irreversible lung scarring, the global medical community desperately needs a unified strategy to spot it on a scan.
You would think so, yes.
But because the triggers vary so wildly by region, different medical societies developed entirely different philosophies on how to interpret these CT scans, which leads to this diagnostic duel.
Right. So we currently have two major competing sets of diagnostic guidelines. On one side, we have the ATS guidelines.
That's the American Thoracic Society, right?
Yeah.
Along with a few others.
Yes. And on the other side, we have the ACCP guidelines, developed by the American College of Chest Physicians.
Okay.
Both of these massive medical institutions, they're looking at the exact same types of thin section CT scans, and they both use a similar three-tier vocabulary to classify what they see.
Which is typical HP, compatible HP, and indeterminate HP.
Correct.
With typical meaning the scan is highly suggestive of the disease, compatible meaning it could be HP but isn't definitive, and indeterminate meaning doctors should probably hunt for a totally different cause.
Exactly. So the terminology is aligned.
The terminology matches, sure, but the philosophical friction comes from the rigidness of their criteria, right?
Very much so. The ATS guidelines are famously strict, particularly regarding the geographical distribution of the lung damage on the scan.
Right, where the scars actually are.
Exactly. To earn a typical HP diagnosis under the ATS framework, the radiologist has to observe highly specific spatial patterns. For example, they require evidence of something called relative basilar sparing.
Meaning the disease must actively avoid the very base of the lungs.
Yes. Yeah.
Now, there's a biological rationale for that, right? Because inhaled particles follow gravity and aerodynamics differently than, say, systemic autoimmune diseases.
That's spot on.
Like a systemic disease that causes fibrosis, like idiopathic pulmonary fibrosis, that often ravages the bases of the lungs first.
It does, yeah.
So by demanding basilar sparing, the ATS is trying to isolate a purely inhalational pattern. They want proof it came from the outside.
That is the exact physiological logic. The ATS draws a very specific, rigid map. But the ACCP guidelines, by contrast, they are far more lenient regarding spatial distribution.
So.
Well, the ACCP framework can grant a typical HP label based purely on the presence of diffuse central lobular nodularity.
Which means?
Widespread, tiny nodules centered around the bronchioles, basically where the air and dust initially land. They don't penalize the diagnosis if the scarring happens to reach the base of the lung.
As long as other contradictory features aren't present.
Exactly.
But hold on, if we are dealing with a disease that permanently destroys lung capacity, my initial instinct is that strictness is safer.
It's a natural assumption, yeah.
Because you don't want to hand out a devastating diagnosis of fibrotic HP if the patient actually has a different, perhaps treatable, autoimmune condition.
Yeah.
So why does the ACCP even offer a more lenient rule book? I mean, it seems like it would just invite false alarms.
Well, it comes down to balancing sensitivity against specificity.
Okay, unpack that.
Think of diagnostic criteria like facial recognition software used by security agencies. The ATS guidelines are like a system that requires a 100% match of a suspect's iris, jawline, and fingerprint.
Highly specific.
Exactly. It virtually eliminates false arrests. But if the suspect happens to be wearing sunglasses, the system lets them walk right through the front door. You miss atypical presentations of the actual disease.
Oh, I see. And the ACCP software, that just scans the crowd for anyone with like an 80% match on the jawline.
Right. It is highly sensitive. It guarantees you will catch the suspect, but you are going to bring a lot of innocent people into the interrogation room who just happen to look similar.
That makes sense, but why would we want that?
Because a highly sensitive, more lenient framework serves a very specific utility in modern medicine. You have to remember, not every radiologist evaluating a CT scan in a local community hospital is a fellowship-trained expert in rare interstitial lung diseases.
Right, they're generalists.
Yeah. A simpler, more sensitive rulebook allows a general practice radiologist to confidently flag a patient, ensuring they get referred to a specialized multidisciplinary board.
Rather than just being sent home with cough syrup while their lungs literally continue to scar.
Exactly. It catches them in the net.
Okay, so we have these two competing philosophies, the strict facial recognition of ATS versus the broad net of ACCP. And the researchers at the University of Chicago actually designed a retrospective study to pit these two systems against each other using real-world clinical data.
They did. They gathered the baseline thin-section CT scans of 297 patients evaluated between 2006 and 2021.
And who were these patients?
They included 200 patients confirmed to have HP, but crucially, they also included 49 patients with connective tissue disease ILD and 48 with idiopathic pulmonary fibrosis.
Ah, so those act as the innocent bystanders in your facial recognition analogy.
Exactly right.
They are distractors with diseases that also cause lung scarring, just to test if the guidelines accidentally mislabel them as having HP.
Yeah, a brilliant study design. The researchers took all 297 scans and had 2 fellowship-trained cardiothoracic radiologists review them independently.
And they were blinded, right?
Completely blinded to the patient's actual final diagnoses. Their only job was to document the physical radiological features present on the screen.
And what was amazing to me is that the initial inter-observer agreement between these two experts was astonishingly high. They achieved a Cohen's-Kappa coefficient of 0.95 and 0.93.
Which is phenomenal.
Yeah, a kappa of 0.95 means we aren't talking about blurry imaging or subjective guesswork here. Two different experts looking at the exact same pixels recognize the exact same physical abnormality.
Yeah, they both saw the same reticulations, the same ground glass opacities, and the all-important 3 attenuation pattern.
Okay, let's pause on that, the 3 attenuation pattern.
Yeah, it's a hallmark visual indicator for this disease. It occurs when a single cross-sectional slice of a CT scan reveals a patchwork quilt of 3 distinct lung densities side by side.
What's the first one?
First, you see areas of ground glass opacity, which on the scan looks like a hazy gray fog.
And that represents active inflammation in the alveoli.
Exactly. Second, you see areas of mosaicism or air trapping. These appear unusually dark on the scan.
Why are they dark?
Because the scarring has essentially squeezed the small bronchioles shut, it traps stale air inside the lobules so it just can't be exhaled.
Okay, so we have the gray fog, the dark trapped air, and the third.
And third, interspersed among the fog and the trapped air, you see patches of completely normal, healthy lung tissue.
So when the radiologists observed this specific patchwork, they agreed on its presence almost perfectly.
Almost perfectly.
Now, here's where it gets really interesting. And it's where the methodology of the study yields its most critical insight. The doctors agreed on the physical reality of the scans. But when they applied the 2 different guidelines to those agreed-upon facts, the ATS and ACCP algorithms produced conflicting diagnoses 21% of the time.
Yeah. Over 1/5 of the patients received a different diagnosis purely depending on which medical society's rulebook was applied to their scan.
Which it's like 2 umpires looking at the exact same pitch in baseball, right?
Oh, that's a perfect analogy.
One umpire, the ACCP, calls it a strike because it technically crossed the plate, while the other, the ATS, calls it a ball because it wasn't perfectly centered in the strike zone.
Yes.
The source even details a 76-year-old woman whose case perfectly isolates this mechanical breakdown.
Oh, right. I remember her case.
Both blinded radiologists evaluate her scan, and they agree she has active scarring reticulation located predominantly at the lower edges of her lungs.
And when they run those exact findings through the lenient ACCP framework, the algorithm returns a diagnosis of typical HP.
Right. But when they run the exact same findings through the strict ATS framework, the algorithm flags the location of the scarring. Because the damage is at the base of the lung, it violates the ATS requirement for relative basilar sparing.
So the software downgrades her diagnosis from typical to merely compatible.
The underlying physical truth of her lungs didn't change at all, but her clinical categorization shifted dramatically.
It really did. And across the entire cohort of 297 patients, the strict ATS criteria categorized 45% of all the scans as indeterminate.
It rejected nearly half the cohort.
Yes. Meanwhile, the lenient ACCP framework categorized 48% of the scans as typical HP.
Which creates an immediate operational crisis for a clinician. I mean, if the guidelines disagree 1 out of every 5 times, how do you know which framework to trust when designing a treatment plan?
Well, the researchers addressed this by analyzing the statistical performance of the guidelines against the actual confirmed diagnoses of those patients.
So what does this all mean? How do we resolve the crisis?
The resolution to the crisis is what we can call the prevalence paradox.
The prevalence paradox.
Right. The researchers discovered that diagnostic accuracy is not a static property of the rulebook. It's inextricably linked to the prevalence of the disease in the specific geographic environment where the test is being performed.
Okay, walk me through that.
To understand the mechanics of this paradox, we really have to look at how Bayes' theorem applies to medicine, specifically through positive predictive value, or PPV, and negative predictive value, NPV.
Okay, those are stats terms. Break them down for us.
Sure, so sensitivity and specificity, which we talked about earlier, they tell us how the test performs in a vacuum.
Right.
But PPV answers the doctor's real-world question. Given that this rulebook just labeled the scan as typical HP, what is the mathematical probability that the patient actually has the disease?
Okay, makes sense. And NPV.
NPV answers the reverse. If the rulebook says the patient is clear, how confident can I be that they truly don't have it? And what's wild is that those values fluctuate violently depending on the baseline prevalence of the disease in the local population.
The UChicago researchers actually modeled this, didn't they? Using the real-world geographic data we discussed earlier.
They did. They calculated the performance of both guidelines in a low prevalence scenario, simulating that 10% prevalence found in the U.S. nationwide registry.
And what happened?
In this environment, the strict ATS guideline is mathematically superior. It achieved an overall accuracy of 92.3% compared to ACCP's 87.6%.
Because the disease is genuinely rare in that population. Like if you use the highly sensitive, lenient ACCP rulebook in a place where the disease barely exists, the algorithm's positive predictive value collapses.
It collapses to 42.9%, yeah.
Wow. So more than half of your typical HP diagnoses would be false positives, pulling innocent people into the interrogation room, so to speak.
Exactly. The stringent facial recognition of the ATS protects the low prevalence population from overdiagnosis. But then, the researchers modeled a high prevalence scenario.
Simulating an environment where 50% of the ILD patients have HP, much like the clinical reality in India.
Right. And in this scenario, the statistical advantage completely flips.
Really?
Yes. The lenient ACCP guideline overtakes the strict one, achieving a higher overall accuracy of 81.7% versus ATS at 79.7%.
So the broad net suddenly wins.
It does, and crucially, in a high-prevalence setting, the ACCP guideline provides a vastly superior negative predictive value.
Because if a disease is everywhere in your environment, driven by pervasive agricultural or industrial exposures, you need a sensitive rulebook.
Exactly. If the lenient ACCP criteria evaluate a scan in New Delhi and declare it indeterminate, the doctor can be highly confident ruling out HP.
But if they use the strict ATS criteria,
they would miss a massive volume of genuine cases because the local presentation of the disease is just too messy and widespread for such rigid spatial mapping.
the strict rules actually become a liability when the pathogen is ubiquitous, which means, and this is the craziest part to me, a pulmonologist in Chicago must fundamentally alter their diagnostic algorithm compared to a pulmonologist in India.
Yes.
Not because the disease pathology changes, but because the Bayesian math dictating the predictive values shifts with the population.
If we connect this to the bigger picture, the study proves that generalized, universal statistical assumptions fail when applied to diseases with extreme epidemiological variance.
You just can't divorce the interpretation of the CT scan from the demographic context of the zip code.
No, you can't. You have to select the diagnostic framework that mathematically aligns with your local environment.
Man, we began this deep dive looking at a microscopic mechanism, right? T cells and macrophages responding to inhaled dust, stimulating fibroblasts to pour concrete into the delicate architecture of the lungs.
Yep.
And then we examined how 2 major medical societies attempted to build standardized rules to identify that concrete on a CT scan.
Yeah.
One using strict spatial mapping, the other casting a wider, more sensitive net.
And ultimately, the researchers at the University of Chicago demonstrated that the pixels on the screen are really only half the equation.
Right. Two experts can see the exact same three attenuation pattern, the exact same mosaicism and ground glass opacity, yet the final diagnosis depends heavily on the statistical reality of the air the patient breathes.
This raises an important question for you, our listener, whether you are analyzing medical data, training financial models, or simply trying to understand how complex systems operate. We often treat data analysis as a search for universal objective truths. But this research highlights that an algorithm designed to be incredibly precise in one specific context can become dangerously flawed when exported to another. The baseline probabilities of your environment dictate the validity of your tools.
The context itself is a vital piece of the data. And here's a final thought to consider, extending beyond the immediate scope of this study. The prevalence of this disease is tied to environmental triggers.
Right. For agricultural zones, specific molds, avian populations.
Exactly. So as global climates shift, altering where those agricultural practices actually occur, and as massive human populations migrate between low prevalence and high prevalence zones, the mathematical foundation of these guidelines will constantly shift beneath our feet.
It's a moving target.
We are currently racing to build automated, AI-driven diagnostic tools for radiology. But if we train an artificial intelligence purely on data from a low-prevalence center in Chicago, relying on those strict ATS parameters, that perfectly trained AI will systematically misdiagnose patients the moment it is deployed in a high-prevalence environment like India.
It's a really sobering thought.
If the accuracy of the algorithm relies entirely on the local map, what happens to our medical certainty when the entire map gets redrawn?